Hi, everybody. Good morning. Thank you for sharing with us this session on neuropelviperineology. On this slide, you see the content of the session today. First of all, Dr. Hamid will present feeling cystometry and pressure flow study. Then we continue with video urodynamic inclusive cystography. Then it will be my part on electrophysiologic examination. And at least Jalesh Paniker will speak on neurological imaging and pelvic neurophysiology testing. Each presentation will take about 10 to 15 minutes. And at the end of each presentation, we have 5 to 10 minutes discussion. So now, Dr. Hamid will start with the first presentation. Dr. Hamid.
Thank you very much, Brigitte, for the kind introduction. I will just share my screen. So I'm going to start with the first presentation, which is the cystomanometry and pressure flow studies. And this is specific to the neurogenic patients, both overactivity and underactivity. And in the end, I'll present some examples or cases. So I've divided my talk into these sections. We'll discuss what is the aim of the urodynamics, what are the basic considerations. Importantly, what are the steps and the techniques, what we need to look for in undertaking urodynamics for a neurogenic patient? How do we interpret it with the help of some cases? And in the end, a word of caution about autonomic dysreflexia, which most of us are aware of. So what is the aim of urodynamics? And as per Schurch in 2002, it is to reproduce the patient's symptoms whilst making precise measurements in order to identify the underlying cause of the symptoms. So in essence, we are reproducing the patient's symptoms. What are the basic considerations? And we are all aware that maturation is a very private matter. Once we are doing the urodynamics, we need to be familiar with the equipment. Our results should be reproducible, and hence the technique should be standardized at least within the unit, if lots of us are doing, within the guidelines. And ICS has got a number of guidelines on this topic, as we are all aware. Like I said, every unit can have their own proforma. This is the proforma which we use at UCLH in London. What we need to do is to, before the day of the urodynamics, like for any surgery, we need to explain to the patient what is the nature of the procedure, and it needs to be done before, not on the day of urodynamics. Always take a detailed history as is outlined on the right side. We need to check for urinary tract infection. Again, different units will have different protocols. Whatever your protocol is, we need to make sure that patient is not symptomatic, and probably we should do a dipstick on the day if the culture has not been done previously to make sure that patient has not got a positive microscopy. And last but not the least, for patients with T6 or above spinal cord injury, we must know whether they have got autonomic dysreflexia. That be the case, either they should have the medication like nifedipine themselves, or one should be available in the department. And I'm going to come back to this at the end of the study presentation. I have purposely, if I might say, made this slide busy just to emphasize that doing video urodynamic studies is probably a job of more than one person. It's quite a complicated test. It's a dynamic test, and we need to know the steps accurately. And on the left-hand side, I've enumerated possibly everything we need to do. One needs to do a cuff test to check for calibration, like here. We start filling at the correct rate. For the neurogenic patients, the ICS recommends between 10 to 20. mLs per minute. We need to open this air escape valve in the water charged transducers. This is not required for the air charged ones. The patients who can lie down, or most of the patients can be done lying down. Some patients will prefer, or some departments will prefer, semi-sitting position. Whatever the preference is, probably we should have the same protocol all the time. One needs to have regular cuffs. Previously, we used to say every minute. Now we say regularly, and especially during the COVID era, one needs to be very careful in asking patients to cough repeatedly, and we need to protect ourselves and the patients. In the filling phase, we need to know what the desire to urgency. Midway through the test, one needs to tilt the table slowly, and this is for those patients who can stand up and pass urine, so that, like here in the video, if you have to take a picture of them passing urine, they need to be slightly oblique, both men and women, so that we can have a good look at the bladder neck. Once in the voiding phase, one needs to ensure that the lines are working well. As you can see here on the left-hand side on this video trace, that as the patient stands up, the vesicle and the rectal pressure goes up, it's well subtracted, and the patient is given the command to pass urine. We need to check that they are passing urine, and one of the advantages of video urodynamic studies is that at the end, one can do an X-ray to ensure that the bladder is empty. And right at the very end, which is probably cut on this slide, is that one needs to ask the patient to cough so that we have got good quality control. How do we interpret the urodynamics? So this is what we are looking for in the filling phase. As we know, bladder has got two phases, filling and voiding, and it's a reciprocal innervation between the bladder and the sphincter on one hand. So during the filling phase, what expects from the bladder is that we'll have normal sensations, good capacity, there should be no overactivity, and the compliance is normal. So what are the sensations? This is awareness to pass urine, and that as the bladder fills up, then the sensations go up. The sensations can be increased, that is early and persistent desire to pass urine, or reduced when there is almost no sensation to pass urine, like in patients with subsacral spinal cord injury, or what we previously used to call lower motor neuron type of injury. In the filling phase, one needs to know about the urethral function also, and the urethral function can be normal when there is no leak. If there is a leak, it can be because of stress incontinence, overactivity, and sometimes because of urethral relaxation, which we all know is somewhat a controversial term. So what is bladder compliance? And here you can see it's the pressure flow as the bladder fills up. According to the ICS, up to 400 mils, one is allowed a rise of 10 centimeters of water pressure. That is a normal compliance. And hence at that level, one can pass it. Now, when this becomes artifactual, here you can see that as the filling goes on, the pressure goes up quite remarkably. How to differentiate between the artifactual and true poor compliance? Once the filling is stopped, if the pressure drops and that slow filling, it doesn't go up, then that was an artificial poor compliance. On the other hand, if the pressure stays and on start of filling, the pressure goes up more, then that is a true loss of compliance. So now I'm going to demonstrate these findings with the help of few cases. So our first patient is a 27-year-old spina bifida patient, hourly frequency and urgency, recurrent urinary tract infections, undertakes self-catheterization on and off, and is on a condom or sheath drainage. And I have put this slide deliberately, as all of you should hopefully can appreciate that this is a very suboptimal study, which we do see from time to time. You can see it's not zeroed well, there are no cuff impulses. So it is not a good study as per the ICS. So this is just to make that point. Having said that, you can see as the bladder is filled up, there is a very true loss of compliance. Pressure goes up. Once one stops, the pressure does not come down unless the patient starts to pass urine, and as the bladder is emptied, the pressure comes down. So this is a true loss of compliance, which can lead to upper tract damage if it is not managed appropriately. Second patient is a 24-year-old T4 spinal cord injury patient, not taking any medications and voids by Credé maneuver. And here you can see a reasonably good study. You can see the abdominal line and vesical lines are zero to the atmosphere, subtracting well. There's cuff impulse, possibly at regular intervals, but you can see this is a classical sawtooth appearance. So urodynamics is kind of part of the radiological investigation, and we go by pattern recognition. So once one sees this tracing, you can see it's a classical sawtooth appearance, very prolonged contraction. So again, the upper tracts are at risk in this case. This is the accompanying video. On the left-hand side, you can see that the external sphincter is contracted. So it's got a sphincter dyssynergia, detrusor sphincter dyssynergia. And if we leave this bladder, then this is what the patient might end up with, which is called a Christmas tree bladder or fir tree bladder, which can lead to upper tract damage and a number of lower urinary tract complications. What about another case? Is a 29-year-old male, and this time it's a subsacral spinal cord injury at the level of L4 for 13 months. The patient is not taking any medications, voids by self-catheterization and Credé maneuver. Here is a completely different picture. On the right-hand side, you can see that all the lines are flat. That means the patient has got no sensation during filling. There's no loss of compliance, no overactivity, and filled up to about 400 mils. And on the accompanying video, there's no reflux. So the patient has got a large capacity bladder, and this patient had also stress incontinence whilst cuffing. There was no appreciable detrusor contraction, and he voids by straining. So this patient is a 35-year-old male who has got a spinal cord injury for about 10 years. There are no particular issues. He empties the bladder with a suprapubic catheter. So what is the indication of doing the urodynamics in this case? We want to find out that his filling pressures or resting pressures are safe. So we do the urodynamics with the catheter. And again, going back to what I said earlier on, it's a pattern recognition. And this is a classical tracing, which is done with the filling is done through the suprapubic tap. So as there is filling, you can see here, then the pressure goes up. Once the filling is stopped, then the pressure comes down. And this is what we measure. Possibly it's got some loss of compliance as up to 420 mils, rise in pressure maybe slightly above 10 centimeter. So one can argue that maybe slight loss of compliance, but the important thing in this tracing is that here the filling is done with the suprapubic. So as the flow goes in, the pressure goes up. You stop the flow to measure the pressure from time to time. And this is the pressure which one needs to take into account for the interpretation in patient who has got a suprapubic catheter. Last few words about the autonomic dysreflexia. This is an extremely important condition to know. And I always tell my colleagues that if you've got a patient who has got an injury level above T6 and it comes to you for urodynamic studies and you have not prepared, i.e. you have not got help and the patient hasn't got nifedipine and you have not got, then that patient must be cancelled or postponed for a later date, because this is a true life-threatening emergency. It generally occurs in patients who have got a spinal cord injury above the level of T6. 90% of the time, the common stimulus is from the bladder, or the fecal loading and skin ulcers or urinary infection can also lead to autonomic dysreflexia. And what is that? It's a massive sympathetic discharge secondary to a specific stimulus. More often than not, it is symptomatic that patients get flushing of the skin above the level. This could be hypertension or reflex bradycardia. But one needs to be aware that sometimes they got asymptomatic autonomic dysreflexia when there's an increase of blood pressure without any symptoms. Hence, for those patients who are prone to getting autonomic dysreflexia, we should be checking the blood pressure as we go through the test. Like anything else, eyes cannot see what the mind does not know. So the most crucial step is management is recognition. One needs to know that this is happening. Majority of the times, once the offending stimulus is removed and bladder is emptied, then and patient is sat up, then the blood pressure comes down. If not, then they can have nifedipine, which can be given to bite, and then the pressure comes down, and the pressure should be measured regularly. If help is not available, then one can call the crash team in the hospital, because this is something which should not be taken lightly, but one needs to recognize this condition. It happens in patients who've got a spinal cord injury above T6 level. So in conclusion, the machinery should be regularly serviced, which someone else will do. Catheters, one needs to calibrate the transducers periodically. Again, it is done by the team in the hospital who looks after the medical equipment, or it's done by the clinical scientist in our department. One needs to check all equipment before calling the patient, have a summary of the steps at hand, so that it's a dynamic step. When the test starts, we don't miss anything in the filling phase, in the voiding phase, in the recording. One must need to know the indication of the study. Like I said, for a cervical patient who has got a suprapubic catheter, all you need to know is what is happening in the filling phase, while somebody who is voiding with a neurogenic bladder, one needs to make sure that the pressures are safe and is voiding, not with abdominal straining and no sphincter dyssynergia. Place line carefully and secure. The lines should be zeroed at the start and adjust as required. Rate of filling should be chosen carefully according to the neurological condition. And cuff should be done at the start, during, and at the end of the study. Going through the test, record the events carefully during the test. It's a dynamic test, so one should record as the test is going on. If any artifacts appear, the test should be stopped and the artifacts should be cleared. Please don't proceed doing a suboptimal study. Other thing is, write the report as soon as the study is finished so that everything is fresh in mind. Watch for autonomic dysreflexia. And if possible, all the studies, and if not all studies, all neurogenic patient studies should be discussed in an MDT for optimal management plan. Thank you very much.
Thank you, Rizwan. Do we have any question? I cannot see. Okay. Rizwan, can I ask you a question? To monitoring autonomic dysreflexia, did you perform continuous monitoring
Brigitte,
of the blood pressure during urodynamic, or you?
Not as a routine for every patient, but like I said, for those patients who are prone to getting autonomic dysreflexia, in those, yes. And especially the ones who say that my blood pressure goes up, but generally I don't get symptoms or get symptoms quite late. For those, it is recommended, and I do check the blood pressure as we go
on. Can I ask you a second question?
Yes, please.
You show us a urodynamic curve on cauda equina patient. Can I see it again?
I have to go back to the presentation, Brigitte. I have, you'll need to give me a few. And
otherwise, we can discuss it at the end of the session.
Yeah, but I've actually just now shared it. Can you see it now?
Yeah.
Yeah, I think I did share it again, because I had my second presentation open, so I think.
Doesn't matter. We can discuss it at the end if you don't find your slide.
Yes, please. Yeah. Okay.
So, and now, Rizwan, you will continue with the video urodynamic studies?
Yes, please, Brigitte. Thank you very much. So I will share my second presentation. Can you see my presentation now? Lovely. Thank you very much. Okay. So the second presentation is on the video cystometrogram, how and why. Again, what is video urodynamic studies? So it is the urodynamic studies along with doing the imaging or X-rays. It is performed with a contrast fluid as a filling medium, and the standard urodynamics with pressure flow studies is combined with imaging to get the video or X-ray images. So as one of my colleagues used to say, with video you see, without video you don't see. So what are the requirements for video dynamics? Or shall I say, what are the additional requirements? And they are, one needs to have a C-arm or urographin, and then obviously the lead aprons. And generally it is done in the X-ray department so that the walls have got lead, and the urodynamics machine obviously is portable. It's a standard machine which you use otherwise. One of the very important things, and I think we need to be aware when buying the VCMG kit, is that the software is very important. And what I've demonstrated here is that you want the video images to marry with the tracing. And this is so important for reviewing the traces later on, especially if you are doing in a multidisciplinary meeting. And this is for both neurogenic and non-neurogenic cases, is that you want to see what is happening. So if this image is aligned with here in cuffing and you can see stress incontinence, you know where the incontinence was. On the other hand, if it was with detrusor overactivity and the leakage is there, you can see exactly what was happening at what stage. On the other hand, in a neurogenic patients, as you start filling the patient up and you can see the reflux going up, you can know exactly where it's happening. So the software, to my mind, is very important once one decides to buy a VCMG equipment. Next thing is the radiation exposure. It should be as low as reasonably possible, obviously without sacrificing the diagnostic accuracy. And as one gets experienced, one uses less and less radiation to get the optimal information. The time and the dose of the radiation should be reported, which is for two purposes: A, for audit, and B, if you're doing the test regularly, we can know that over a period of time, we are actually improving our ability to use less radiation and get more information. So what can we see with video dynamic studies, which we can't see with standard urodynamics? So you can see the reflux in the bladder, like I showed in the earlier presentation, and we are going to see again. You can see the diverticula, you can see the trabeculations. If there's a Christmas tree bladder, you can see if there's a fistula between vagina and bladder, or between prostate and bladder. If there's a cystocele, then obviously observing for the urinary incontinence, what type of incontinence it is, and we can grade it with the Blavis grading if we use that system of grading for incontinence. And you can see the various abnormalities in the urethra, whether there are stricture, diverticula, or dyssynergia. The important thing in urodynamics is to know when to screen. So you can do the screen at the start to see what the post-void residue is, to evaluate for urinary incontinence during peak detrusor overactivity with a reflux, and during the voiding. So you can see all these things. What are the clinical indications to do video urodynamic studies? And it's very important to know when to do it. As for the EAU and SUFU guidelines, The top is the neurological condition. Any person who has got a neurological condition, I think most of the guidelines agree that the first urodynamics should be done with video urodynamic studies. And once it's established, then one can go on later on to do the standard urodynamics. In congenital anomalies like valves or reflux, video urodynamic studies is recommended. In bladder outflow obstruction, in complex cases, especially those who had previous outflow surgery, history of radiotherapy, pelvic reconstruction, or the ones in which we are suspecting a fistula between various pelvic cavities, then the video urodynamic studies is preferable. And obviously, if one suspects any abnormality in the urethra, then one can see on the voiding study. Sometimes one can see things like that. And here the filling was started, and then it was not noticed that the patient is leaking initially before the patient said that I'm leaking. Video was taken and the line was in the vagina. You can very clearly see that everything is coming out. Similarly, later on, if it is done, you can see that some of the contrast is still there, which can be because if the contrast is not completely drained, or it can be in the case of a fistula like here. One can see the reflux. You can see as soon as the bladder was started to fill up, it goes up on both sides. So if there is no video, then it can give a false sense of security that the pressure in the bladder is not going up because both the kidneys are taking up all the contrast. It can also come in this stage that once the bladder is very full, you can see there's some contrast is going up the right ureter. One can also grade the reflux, and also you can see on the right side if there is a bifid duplex system, that can also be picked up on the urodynamic studies if there is a reflux. Bladder outline can be seen, and here you can see there is a diverticula which can be seen here, and here you can call it a Mickey Mouse bladder. This can be as a part of an outflow obstruction or can be congenital, but this is a morphological picture or an anatomical of what the bladder is like, and that can be the only cause of having infections. If there's any indentation from other organs, that can also be picked up as the bladder is filled up. And of course, this is a classic neurogenic bladder with a fertile appearance with the dilated prostatic urethra. One can, from time to time, see conditions like this. You can see a bit of prolapsed bladder on the MRI, which can be a source of infections which one has not been able to diagnose beforehand. This can be diagnosed on urodynamics. A rare diagnosis, but can happen. Now, those were on the filling phase. What we can find on the voiding phase, this probably, when all of us can agree, is a normal void where the urethra is open. This is in contrast to this one, where one can see that there's a dilated urethra above a stricture. You can see this is like a beak. So it is a classical stricture. Here is voiding with a cystocele. Again, in an oblique position, one can find out that the urethra is kinked because of the cystocele. On the other hand, a patient who has previously tape, one can see that this is the obstruction from the tape, which is not beaten. You can see with it is slightly more in a U-shaped fashion. So this is post sling surgery obstruction. One can also find something like this, which is non-relaxing sphincter. And one can see here the contracted and the relaxed one. And you can see the picture is somewhat different, although the proximal urethra is still dilated, but at the level of the sphincter, one can see contraction. A similar case, somewhat different, where the bladder is very full. One is asked to pass urine, nothing is coming through. And you can see a slight opening of the bladder neck because the sphincter is contracted belowhand. Again, case of non-relaxation of external sphincter. A patient presents classical description that post-maturation dribble in a female, if you do the, or with recurrent infections, and you can see here, this is a urethral diverticulum in a female, which can be very nicely picked up in a voiding phase of urodynamics. Coming up to some male voiding pictures, you can see probably we can agree that this is a normal void, which is different to the classical narrowed bladder neck. And here you can see the white side trapping once the patient is asked to stop passing urine, with the contrast trapped in the prostatic urethra. This is a male voiding where the bladder neck is open, but the sphincter is not opening very well. Again, it can be either, if a neurogenic patient, it's a DSD, if it's a non-neurogenic, then it can be a voiding dysfunction patient. This patient has had a TURP and then could not pass urine very well, wide open urethra or prostatic urethra, and a stricture at the junction of the prostate with membranous urethra. Classical neurogenic patient, tuberculated bladder, and reflux into the prostatic part. This is again male voiding and probably it's got a dilated bladder neck, possibly a stricture at the vulvar level. What about the neurogenic cases? You see a classical sawtooth appearance of a neurogenic detrusor overactivity with sphincter dyssynergia, and I've put in autonomic dysreflexia in red because the patient has got an injury above the level of T6 and hence can have autonomic dysreflexia. And if we leave this condition over a long period of time, then this can happen, which is a tertiary bladder. Probably the bladder will have loss of compliance, might be putting pressure on the upper tracts, leading to renal failure, or incomplete emptying, leading to infections. Again, to demonstrate why one needs to do urodynamics in a neurogenic case, like I said, if you start filling up this patient, there's no video, then the patient can have 500-600 mils with no rise in the pressure, and it can give us a false sense of security that the bladder pressures are low. But in this one, the picture, you can see very clearly that all the fluid, or most if not all, has been taken up by both the kidneys with very little in the bladder. Few slides about the SUI classification. We use the Blavis type classification, which can be very nicely demonstrated into type A, type 2A, 2B, and type C. And this is a type A or type 1, which is that the bladder neck is above the inferior border and the descent is less than 2 centimeters. In type 2A, the descent starts above the inferior level, the descent is more than 2 centimeters. In type 2B, it starts below the inferior border of the symphysis and descent is further. And type C is intrinsic, or type 3 is intrinsic sphincter deficiency. It's important to do video dynamic studies because if you know what type of incontinence it is, it can help counseling the patient with various types of anti-incontinence surgery. So in conclusion, one should know the urodynamic question and indication for study, know your equipment, minimal exposure in video cases to get the maximum information, always save the images as one goes along, record the test very carefully. Like I said before, correct the artifacts as they appear, report the study as soon as one is done, watch for autonomic dysreflexia in spinal cord injury patients above T6, discuss all studies in the MDT if possible, and don't wear your best shoes. Thank you very much.
Thank you, Rizwan. I don't see a question on the chat. Roger, do you see any question? I have a question to you. Rizwan, not every urologist will see a neurogenic patient as a possibility to perform by video urodynamics. So what do you will recommend to these urologists who don't have the possibility to perform video urodynamics?
In that case, Brigitte, what you do is to do a standard urodynamics, but get a maturating cystourethrogram, so that one can know that as the bladder is filled up, is there any reflux, and during the voiding, if there's dyssynergia or there's a reflux during the voiding. So I think that combination can happen, or one should do it in that sense, at least once, so that we get baseline evaluation. And then if there is a change, like somebody starts getting recurrent infections or incontinence, then that can be repeated.
Thank you. And what do you recommend for the yearly follow-up of your patient, spinal cord injury patient?
Now, most of the guidelines have somewhat changed, especially the NICE guidelines say that patients who have got a high-risk bladder, that is, patients who have got suprasacral spinal cord injury, patients with spina bifida or complex problem, should have urodynamics, if not yearly, at least once in 18 months. The ones who have got subsacral spinal cord injury or got a stable neurogenic condition, then it can be done if there is a change in their condition, like infections, incontinence, but they should have a yearly ultrasound scan.
We have what happens when reported symptom doesn't match with your dynamic findings?
Thank you very much. That can happen from time to time. And the role of urodynamics is to replicate patient symptoms. If we have not been able to replicate the symptoms, it can be because at that time the patient was not having symptoms, patient was anxious. If there's avoiding symptoms, we have not been able to do a voiding study, or if the study is done optimally, we still have not been able to replicate their symptoms, then I think one should go on and do ambulatory urodynamics to give a diagnosis, especially if we want to offer a surgical intervention.
I have one question, Brigitte. With the tristal sphincter dyssynergia, this can happen at the level of the external and the internal sphincter. And my question is, from your experience with VCMGs, how often do you find internal sphincter dyssynergia to be significant in regards to contributing to an obstructed void?
I think Bridget's question was to you or to me?
That was me. That was to you, actually, Rizwan.
Oh, fine. Okay, no, sir. Yeah, no. So, Jalesh, very really, to be honest, I've seen a definite internal sphincter dyssynergia. More often than not, it's almost always external. In some cases, I've seen the internal one when we used to put the wall stent for the to overcome or external sphincterotomy, and in those cases, the internal sphincter becomes pronounced. But apart from that, I have hardly ever seen internal sphincter dyssynergia to an extent that it causes upper tract problems or difficulty in bladder emptying.
Thank you.
So I don't see any question anymore. I just want to make a correction of the program. Just after my presentation on electrophysiological testing, Jalesh will continue with the same topic, and at the end we will have neuroimaging. Is it right, Jalesh?
That's correct. Thank you, Brigitte.
So I will start with qualitative and kinesiologic EMG. And the question is how, when, and why. So the kinesiologic EMG, okay, I'm sorry. Okay, sorry about that. So the first topic will be qualitative and kinesiologic EMG. So what is the aim of kinesiologic EMG is to assess the pattern of pelvic floor activity during bladder filling and voiding. For this, you can use various surface or intramuscular needle or wire electrode, and the bioelectrical activity will then be sampled for a single detection site. But up to now, there is no commonly standardized technique for kinesiologic EMG. The limitations are that when you use a surface electrode, there will be problems related to the validity of the signal. For example, artifacts, movement artifacts, or contamination from other muscles of the pelvic floor. And in contrast with intramuscular electrodes in large pelvic floor muscle, there are questions as to whether the whole muscle is properly represented by the measured signal when you use a needle EMG. Given the potential difficulty in detecting muscle activity by kinesiologic EMG, the ICS guideline on urodynamic equipment and standardization recommend that EMG during urodynamic should have a high input impedance, a common mode rejection greater than 80, and a filtering program to best produce a consistent EMG during testing. But up to date, almost all urodynamic machine has the equipment to participate to this requirement. It generally assumes when you register EMG of the sphincter that part of the levator ani and sphincter muscle act in coordination fashion. However, there are differences between intra and periurethral sphincter in normal women, which means that you will not always be able to be sure that you are registered the signal you want. So the normal sphincter activity by normal individuals show continuous activity in motor urine potential at rest, which increase voluntarily and reflexively. You see, for example, after cough, you have a reflex contraction of the external urethral sphincter. And normally, in a normal condition, you have a diminution or even a disappearance of all EMG activity in the external urethral sphincter, which precede or follow the detrusor contraction. In case of a neurological disease that impair the ability of the pontine micturition center or its pathway to coordinate function of the lower urinary tract spinal center, it will lead to detrusor contraction, again a contractic outlet, and this is called detrusor sphincter dyskinesia. And detrusor sphincter dyskinesia usually occur in patients with suprasacral lesion and is uncommon in lesion of the lower cord. Detrusor sphincter dyskinesia, as defined by the new standardization committee, describe a detrusor contraction concurrent with an involuntary contraction of the urethral and or periurethral striatal muscle, and occasionally flow may be prevented. The detrusor sphincter dyskinesia has been classified according to Blevas based on the temporal relationship between urethral and bladder contraction. In type 1, you will have a crescendo increase in the EMG activity that suddenly relax at peak of detrusor contraction. In type 2, you will have clonic sphincter contraction interspersed throughout detrusor contraction. And in type 3, you will have sustained sphincter contraction that persists throughout detrusor contraction. And this is of relevance for the risk for the upper urinary tract because it is known that type 2 and type 3 are more at risk for the upper urinary tract. Well proposed a more simplified characterization based on whether EMG activity was continuous or intermittent or clonic or spastic. But both criteria are inconsistently applied to categorize detrusor sphincter dyssynergia today. So in conclusion, kinesiologic EMG aim at assessing a pattern of AOS mostly during voiding, and sphincter activity during voiding in healthy individual is characterized by the cessation of all EMG activity prior to detrusor contraction in normal condition. Needle electrodes are more useful than perineal patch to demonstrate muscle unit quiescence during voiding. However, needle electrodes are not always possible, especially in children. Pathologic incoordination of the detrusor and the sphincter, so-called detrusor sphincter dyssynergia, may be assessed by kinesiologic EMG during cystometry, but sometimes you have some artifacts which impair the resolution of the tracing. And apart from polygraph urodynamic recording to assess the detrusor sphincter coordination, the diagnostic usefulness of kinesiologic EMG is still to be established.
Brigitte, perhaps I can ask a question. You showed sort of kinesiological EMG recordings, and in labs that perform this, it's always surface EMG that's recorded. How specific is surface EMG in recording activity from the sphincter muscle in contrast to the general muscle activity that has been picked up from the pelvic floor?
So as I told, surface EMG, surface electrode for kinesiologic EMG are more easy to use than needle EMG. But you are right. You have to place. We place the electrode very close to the anus to avoid artifacts from contraction of the perineal muscle, co-contraction of perineal muscle, or gluteus maximus. We manage to have most of the time good tracing, but I agree with you. If the electrodes are too close to surrounding muscle, or if the electrodes are wet during voiding, you may have artifacts. The problem is that needle EMG is not feasible for all patients. We perform in multiple sclerosis patients urodynamic in sitting position, so it's difficult to perform with needle electrode. And in children, it's almost impossible to put needle electrode.
Can I ask a question?
People are using, yeah.
Sorry, going on from there. So what I want to ask is that then is there an indication to do surface electrodes for all patients once we are doing the urodynamics? What we do is that we don't do any surface electrodes. We do the VCMG, and the ones who we feel require EMG, we send them to Jalesh so he can do the specific needle electrodes, and in that way we get more information. Do you think that is a more reasonable approach?
But I think what will perform Jalesh as this type, then it will be a quantitative EMG, which is different than kinesiologic EMG. Kinesiologic EMG you have to perform during neurodynamic. Otherwise, it is not a kinesiologic EMG. So I think in spinal cord injury, it matters to perform kinesiological EMG during urodynamic. In MS patient, you can discuss it. We perform in all neurologic patients kinesiologic EMG during urodynamics, but if you make video urodynamic, you may be able to see on your screens diffuse or sphincter dyskinesia. But if you don't have video, I think it's worthwhile to try.
Thank you.
And I'll perhaps add to that it's very much what is the clinical question? And I suppose if it is to demonstrate DSD and in a setup, as Brigitte mentioned, where there isn't a video dynamics facility available, I suppose an alternative to the option that you mentioned in the last Q&A would be a cystometry with a surface EMG recording. But I think more and more units are moving away from kinesiological EMG, partly because VCMG facilities are now becoming available in more units.
Yes. So if there is no question, I will move to the next talk.
Thank you.
Okay, the second part of this electrophysiologic recording or testing are the vegetative testing. So, as you might know, all the neurophysiologic methods for evaluating of the neurologic bladder, like EMG, electroneurography, somatosensory evoked potential, assess mainly the cecum myelinated fibers only, whereas it is the autonomic nervous system which is the most important for the bladder function. It might, in most instances, that local involvement of both somatic nervous system and autonomic nervous system is present, for example, in cauda equina, but there are some pathologic conditions that cause isolated autonomic nervous system disorder. For example, small fiber neuropathy, pure autonomic failure, or neurogenic disease after hysterectomy or rectal surgery. And therefore, method assessing the parasympathetic and the sympathetic nervous system are required. So, starting with the sympathetic skin response, the sympathetic nervous system mediates sweat gland activity on the skin, and on stressful stimulation, for example, electrical stimulation of the contralateral and potential shift can be recorded with surface electrodes from the skin of the palm, the perineal. The sympathetic skin is the reflex that consists of myelin, a complex central integrative mechanism, and a sympathetic efferent chain. So, for obtaining sympathetic skin response, we of the end of the foot, we use conventional electromyograph. Then this electrode will be attached to the ventral and the dorsal surface of the hand. We use the right hand mostly, but you can also use the left, or the foot, and also at the perineum. And the stimulus used in clinical practice is usually an electrical pulse given at the contralateral wrist at the medial nerve, or at the ankle at the tibial nerve. So many years ago, we were assessing a different pattern of sympathetic response in spinal cord injury according to the level. And what we found, it was that we found 4 different types of sympathetic screen response according to the level of the lesion. For high cervicothoracic lesion, what we found is because the lesion is above the sympathetic outflow, what we found is that when stimulates the right end, you didn't find any answer in the palm, in the foot, and in the perineum. And for thoracic lesion, because part of the sympathetic outflow is out, what we found was a positive answer in the end, no answer in the foot, and no answer in the perineum. And for thoracolumbar lesion, what we found was answer in the end, answer in the foot, no answer in the perineal. And for lesion below the sympathetic outflow, we found a normal pattern, which means answer in the end, answer in the foot, and answer in the perineum. And what we perform thereafter, we correlate this finding with urodynamic in spinal cord injury. And what we found was that the palm and the sole sympathetic skin response seems to be useful in the assessment of bladder neck dyskinesia as well as autonomic dyskinesia in spinal cord injury. Because all our patients would demonstrate bladder neck dyskinesia and autonomic dysreflexia during urodynamic as a pattern of type 1 and 2. And what we also found is that the perineal sympathetic skin response seems to be significantly correlated to the bladder neck function, which means incompetence versus competence in urodynamic, at least in spinal cord injury, because we found that all patients with a type 3 sympathetic skin response pattern had bladder neck incompetence during urodynamic. Another way to test the sympathetic nervous system are the scrotal reflex, because the scrotal reflex depends on the integrity of the thoracolumbar segment and consists of elevation of the testis and retraction of the penis. There are 2 different scrotal reflex, the cremastic reflex and the dartos reflex. The cremastic reflex is a striatal muscle that originates from the internal oblique muscle and descends along the spermatic cord. And the dartos muscle is a smooth muscle found in the dermal layer of the scrotum. And contraction of this muscle in response to cold result in minimizing heat loss. The dartos muscle is important for testicular thermoregulation and spermatogenesis, and therefore functional properties and quantification of dartos contraction might provide information pertaining to the etiology and pathophysiology of male infertility. In one paper from the Amarenko group, that dartos reflex was evoked by applying a small ice pack on the scrotum separately to each side. And the dartos reflex of the scrotum was rated as absent or present. And when present, the elevation of testis could be incomplete or complete, which means full migration of the testis into the inguinal canal. And it appears, according to this study, that the presence of absence of the detusor of the dartos reflex is predictive of the functional status of the thoracolumbar sympathetic spinal segment. And presence of the dartos reflex seems to be strongly related to an intact thoracolumbar segment. last vegetative testing is the bladder smooth electromyography. And neurophysiologist tests of sacral parasympathetic nerve function, such as detrusor or EMG, will in principle be the most definitive indicator of neurogenic bladder involvement, because detrusor is innervated by the parasympathetic nerve system. Many years ago, Matti Kinder published a recording of EMG of the detrusor during neurodynamics. And what he found, it was that during detrusor contraction, you have a nice increase in the EMG activity of the detrusor during bladder contraction. However, EMG of the detrusor is confronted with problem in discriminating between very small extracellular membrane potential changes in the bladder cells and the large electromechanical artifact caused by electrode movement and the bladder contract. Effectively, most of the time when the bladder contracts, you will have artifacts in the recording. So in conclusion, the autonomic nervous system is the most relevant for lower urinary tract function. The skin response might be useful in the assessment of neuropathies involving unmyelinated nerve fibers and thoracolumbar sympathetic function. We found nice correlation between sympathetic skin response and detrusor bladder neck dyssynergia, as well as with urodynamic finding of bladder neck competence versus incompetence. But up to now, most of these tapes described in this presentation have essentially a research purpose. The utility of the Dartos reflex, which is less invasive and less complicated, still need to be confirmed. And at least neurophysiologic tests of sacral parasympathetic nerve function, such as detrusor EMG, would in principle constitute the most definitive indicator of neurogenic bladder involvement, because it tests the parasympathetic nerve system. However, further studies to improve and validate these tests are expected to clarify their place in research and clinical practice. Thank you for your attention.
Maybe I can start with a question. So we've been recording the perineal sympathetic skin response in many of our patients, and it's interesting, we've not been able to find a consistent pattern. I mean, this is in regards to the group of patients with sacral Tarlov cysts. So these are patients who have a sacral root lesion. So this is well below the thoracolumbar outflow. Interestingly, in some patients, we find the SSR to be preserved. In other patients, we find it to be absent. I just was wondering whether you had any thoughts about that. We thought that the pathways can be different, though the sympathetics leave at the thoracolumbar segments. There's some research to suggest that actually they do descend along pathways and can actually emerge along with the sacral roots. And so this is where we were thinking perhaps there could be some involvement, but I was wondering whether you've had any experience in other indications with the SSR.
No, we only perform it with the result of the study I present to you was only in spinal cord injury patients.
Another question. So the Dartos reflex and the SSR both assess the thoracolumbar sympathetic outflow. Do they give you different information? So if you were to set up, if anyone in the audience was interested to set up a pelvic neurophysiology unit, part of their neurourology service, should they be investing in both of these, or do you think one alone would be useful to assess the sympathetics?
No, I think you can either study one or use one or the other, but I am not aware on the value on cremaster reflex I have no study comparing Dartos reflex and cremaster reflex to demonstrate that it's a good way to test thoracolumbar sympathetic outflow. The only study I found was on the Dartos reflexes, which is less invasive and more simple than a sympathetic sinus response recording.
Thank you.
No, I have no tip to prevent wet electrode. But you know, we perform mostly, except in high thoracic or cervical lesion, we perform urodynamic seating, which means that it prevent a little bit that the electrode will be wet. But I have no, if the electrode is wet, then you will measure artifact. No, I have no way to prevent that the electrode are going wet during urodynamic, especially if the patient is lying. So I think there is a question for you, Rizwan. What you think about use heart rate deep breathing test?
For what? Anna, can you please?
Or perhaps somebody is thinking about using heart rate variability during neurodynamic. Perhaps it's a question related to using heart rate variability during urodynamic.
So the background, Rizwan, is that with heart rate variability, there's a so with deep breathing, there's a heart rate variability in the heart rate. It's a marker of parasympathetic functions. I suppose the question is, can you correlate that with parasympathetic activity at the level of the detrusor? I suppose that's the question.
Yeah. The honest answer is, to be honest, I do not know. I've not actually read about it or heard about it, that just the heart rate going up and down is directly linked with the detrusor overactivity. So
no, but because with heart rate variability and Fourier transformation, you may be able to distinguish between sympathetic and parasympathetic nervous system according to the frequency. But we perform it during study aiming at assessing the anticholinergic function on the bladder and on the heart. But we use only for research purpose. We don't use routinely heart rate variability during urodynamic, because it means that you have continuous monitoring of the heart rate and the blood pressure during urodynamic, and not everybody are able to do that. But yeah.
I was going to say, there's a third question that's come from Ms. Lopez, and perhaps I can answer that one because it sounds more neurological. So I think all the quantitative sensory tests for small fibers, that's the question. There are certainly tests, including heart rate variability and other autonomic function tests that are available. The Valsalva,
yeah.
And they will tell you about, in general, about autonomic functions. And this is in regards to cardiovascular regulation from the autonomic system. But in my knowledge, there's nothing specifically for urogenital functions. So I will just load my slides. Can you see my slides?
Yes, we can. I think you just need to read the PowerPoint mode. like the presentation.
There you go. Thank you. Thank you, Brigitte, for the introduction. And so my name is Jalesh Paniker. I am a neurologist at the National Hospital for Neurology and Neurosurgery at Queen's Square in London, associate professor at UCL. And this topic is on pelvic neurophysiology testing. Essentially, the purpose of this talk is to convince you, the non-neurophysiologist, about why you should introduce neurophysiology into a neurourology service. And so the role of pelvic neurophysiology tests, many of which we've heard from Brigitte, is to assess whether there's evidence for damage to the pelvic somatic innervation, either the peripheral or central. And the sort of patient groups who will come to a neurourology unit in whom these might be applicable are patients who present with urogenital, bowel symptoms, or pelvic sensory complaints such as numbness or pain. And these could be in two contexts. One is in the context where there's no diagnosis, these symptoms remain unexplained, and as a clinician, the question is there a neurological cause? And the second context would be those in whom there is an established neurological disease. Now, remember that the neurophysiology testing that I will be discussing is predominantly of the somatic innervation. So it doesn't tell us about the autonomic innervation. Also, it tests the large myelinated fibers. And as you heard from Brigitte, to test these thinly myelinated fibers, the autonomic nervous system, one might adopt the sympathetic skin response or the Dartos reflex. Now, there are different tests are available, and the reason being that for a battery of tests is because they assess different parts of the innervation. So if the clinical question is to study the sensory pathways, then you have one test that can assess both the peripheral and the central sensory pathways, and that's the sensory rote potential studies, such as the pudendal-sensory rote potentials. Now, if the question is in regards to is there a lesion affecting the peripheral sensory pathways, then one might perform a test such as a dorsal penile nerve conduction in a male patient. Now, what about if one would like to assess the motor pathways? Then to assess the stretch of the pathway between the motor cortex and the muscles of the pelvic floor, one has the motor rote potentials recordings. And if it's the peripheral part of the motor innervation from the sacral spinal cord, i.e. the ONF nucleus, to the pelvic floor muscles, it could be either measuring the pudentomotor terminal latencies or pelvic floor EMG. Now, there is one test that assesses both the sensory and the motor pathways of the peripheral innervation, and that is the bulbocavernosus reflex. And to provide the entire overview, if in the clinical question to the lab is to assess the autonomic innervation, you heard about the sympathetic skin response and Dartos reflex. So essentially, these are the around 6 or 7 tests that are available in the remit of pelvic neurophysiology tests, and the ones that you select depend upon the clinical question. Now, we heard about surface EMGs earlier. With concentric needle EMGs, it is specifically into a muscle, and hence there's no noise from the pelvic floor. You can study specifically from the individual muscles, and as it was pointed out in a Q&A session, it's a quantitative EMG in contrast to a kinesiological EMG, which is a qualitative EMG recording. And of course, once again, the purpose of these are different, because concentric needle EMG is more in regards to diagnostics, if there is a damage to the innervation to that muscle. So if the damage to the innervation is somewhere between the anterior horn cell, which for the pelvic floor muscles is the ONF nucleus, or the sacral motor nerve root, or the pudendal nerve, or and its branches to the anal sphincter, the urethral sphincter, then this study will help provide innervation information about this. Now, there are some specific situations, such as if a patient comes with Parkinsonism, and you think, or you've been referred a case of Parkinson's disease, but then you find the patient in urinary retention. Now, Parkinson's disease should not be associated with urinary retention. And you think about the differential diagnosis of multiple system atrophy, where the ONF nucleus undergoes degeneration, in which case performing an anal sphincter EMG would be useful. This test is able to tell you about reinnervation and to a lesser extent about active denervation. One could perform a urethral sphincter EMG for the very same reasons. However, it is more technically challenging. And so to answer the question whether there's an injury to the sacral roots, one usually performs an anal sphincter EMG over a urethral sphincter EMG. However, in a cohort of young women with retention, where there is a primary disorder of urethral sphincter relaxation, there is a specific EMG finding in the urethral sphincter of complex repetitive discharges and decelerating bursts. And so in this clinical indication, then one would actually perform a urethral sphincter EMG over an anal sphincter EMG. And these are examples of the motor unit potentials. Those of you who are familiar with EMGs will recognize that these are very small amplitude motor unit potentials, and the duration is usually less than 10 milliseconds. Moving on to evoked potential studies. So this is now involving electrical stimulation, and the standard test is to stimulate the tibial nerve and record, and this is by repeated stimulations of around 150, a burst of 150 runs of electrical stimulus, which is delivered around sort of 3.1 hertz, and recording from the somatosensory cortex. Now, instead of the tibial nerve, one could stimulate over the clitoris or the dorsal clitoral nerve, or over the penis, the dorsal penile nerve, and one gets the pudendal-sensory potentials. These are recorded from the scalp in the same sites as for the tibiosensory evoked potential, and assesses the afferent sensory pathways. Now, what we look at is a latency of the cortical response, and this is influenced by many factors, including the length of the neural pathway. However, interestingly, the latency of the pudendal sensory evoked potential is comparable to that of when performed in the leg with the tibio SEP. So if there is a suspected lesion of the sensory pathways of the conus medullaris, the cauda equina, the pudendal nerve, or the spinal cord, this is a useful test. And the finding of a normal pudendal SCP can help rule out a neurological cause in individuals who present with sexual dysfunction, such as genital numbness or possibly even erectile dysfunction. And there is also value in recording of steps following clitoral stimulation intraoperatively in patients undergoing surgery for cauda equina or conus lesions. Those of you familiar with SEPs will recognize this W-shaped pattern. This W is the normal morphology of the tibiosensory evoked potential, and one looks at the first downward deflection, which occurs roughly 40 milliseconds afterwards, and hence it's called the P40 response. You'll see that when in this male patient, when the dorsal penile nerve was stimulated, you have a similar W-shaped pattern, similar latency, and we also look at the P40 response. I move on to the bulbocavernosus reflex. And as I said earlier, this assesses both the motor and the sensory peripheral pathway, consisting of the pudendal nerve, the sacral roots, and the sacral spinal segments. And one stimulates either the dorsal nerve of penis or the clitoris and records from the bulbocavernosus muscle or possibly the external anal sphincter. And the test assesses the sacral roots in patients with bladder dysfunction, and there is a role in intraoperative monitoring. This is an example of a patient who's had a bulbocavernosus recording. The latency here was 30 milliseconds, so well within the range for men. And we have a response like this, which tells us that the integrity of that peripheral pathway is intact. So in conclusion, you have a battery of neurophysiology tests, which such as the EMGs, the bulbocavernosus reflex, different sensory evoked potentials, and sympathetic skin response. And the choice of test depends on the clinical indication and the side of the neural pathway that you want to assess. If you'd like to assess the sacral motor somatic pathways, such as the anterior horn of the sacral motor roots, the pudendal nerve, you would go for an EMG study. The bulbocavernosus reflex would also give you some information about that, but also about information about the sensory pathways as well. Whereas if you'd like to study the somatic sensory pathways alone, it would be performing a sensory evoked potentials. There are specific indications for performing these tests, but in a neurourology unit, you will find that these sort of clinical questions will come upon time and again. Thank you very much.
So, Jalesh, how routinely you use SCP and MEP for investigation of neurogenic bladder?
That's a very good question. So if the question is about assessing the neurogenic bladder or a bladder dysfunction, and if it's neurogenic or non-neurogenic, then I don't think this test will be very helpful. It's the accompanying baggage. So in addition to bladder, if there's bowel and sexual dysfunction as well, or perhaps sensory impairment, then these tests have a role. But I would say that if, for example, a patient with urinary retention is perhaps one condition where it might be useful because you are suspecting a lesion of the roots rather than a central nervous system pathology, then here once again assessing the sacral innervation is useful. But I think the important caveat is that we're assessing the somatic innervation and not the splanchnic or autonomic innervation. So the tests are performed, but it's the interpretation of the test results that are as important. And so when we run these tests, we do have a bi-weekly clinic. All the results go to an MDT where we discuss the results in light of the clinical context before a report is issued.
What about intraoperative monitoring for Tesserod-Court syndrome surgery or scoliosis?
I think there's a very useful role. There have been studies that have shown that that these are effective and in actually preventing injury to the sacral roots. The studies, however, are limited in regards to what extent they have in preventing bladder dysfunction. But I think in centers that have facilities for pelvic neurophysiology, I think it's an important step to liaise with neurosurgical teams, because it would be interesting to see if this can alter the outcomes in terms of neurogenic bladder, bowel, sexual dysfunction after these sort of surgeries.
If you want to classify your investigation, what will be for you the most important for a neurogenic bladder?
That's a very difficult question. I would say that if it's just a pure bladder dysfunction, I would say that it's more for the ones with voiding dysfunction rather than storage dysfunction that I think there would be a role for pelvic neurophysiology. And in that context, if you were to ask me to say one specific test, it would be probably a urethral sphincter EMG in a woman with retention.
And correct differentiated situation, Parkinson and MSA.
Clearly, yes. So now that you've given me the option to provide my number 2 priority, then I would agree the other group would be the ones that come to a neurourology unit where there is a Parkinsonian syndrome with neurogenic bladder. And if there is some uncertainty about the diagnosis, the neurourology unit could actually contribute to that by neurophysiology by performing an anal sphincter EMG or a bulbocavernosus reflex, because both have been shown to be affected in MSA.
So we have a question from the floor for you, Jalesh. What do you think about the use of intravesical electrode to make evoke potential of either external sphincter and bladder cupula?
So I think this is an exciting piece of work, particularly the group in Balgras have done quite a bit of tremendous work using measuring sort of sensory evoke potentials using intravesical electrodes. I think in the research realm, it clearly has shown robustness. From clinical applications, I think there are several studies that are required to demonstrate where this will have a role in clinical assessment of patients.
Okay, actually, I had also a presentation of electrophysiological testing, but it overlapped your presentation and we are running out of time. So I propose Jalesh will continue with neuroimaging.
Thank you. So I am just sharing my slides. Thank you. So this last presentation is on functional CNS imaging. So, so the questions that one has when about the central control of the lower urinary tract is what has actually led to advances in functional imaging in the context of understanding bladder dysfunction. And there are several questions that come up. What are the changes that are seen in brain activity with bladder filling? What changes are seen in lower urinary tract dysfunction? Do treatments for lower urinary tract dysfunction reverse these changes? And can these changes be used as an imaging biomarker for dysfunction and its treatment? Sadly, we don't have answers to most of these questions, but it does open up the intrigue and also open it to listeners of this module in regards to future research questions. So to detect changes in the central nervous system, what we're alluding to is essentially brain activity. And this can be detected either by looking for changes in metabolism or blood flow. So you could have a SPEC study, as you can see from this is from the 90s, and then more recently PET studies, and you have functional MRI studies and near infrared spectroscopy. So different sort of ways to assess these changes in either blood flow or changes in metabolism. Or to detect changes in brain activity, you could look at the changes in electrical activity and magnetic signals. So either like EEGs or magnetoencephalography or MEGs, or looking at even the evoke potentials that you heard earlier is a form of sort of imaging, but looking at electrical signals rather than changes in blood flow or metabolism. And we focus on just imaging either PET or fMRI today. And the principle in PET studies is that you have an unstable molecule, essentially a tracer that's emitting positrons. For example, you have water that sort of has an O15 isotope, and this is injected. And in the brain, there's a relative increase in blood flow during an experiment, and thereby there's an accumulation of the tracer. So what happens is the positron that's emitted collides with an electron, and there are two gamma rays that are released. So essentially the patient is lying in a scanner that detects gamma rays, and based on the changes in activity, one gets an idea about essentially a change in metabolism that happens, and that's the signal. Now, when you look at changes in blood flow, it's something different. Now here, there's no radiation. You don't look at metabolism here, but the assumption is that there will be an increased blood flow to brain regions that have a heightened neural activity. So when there's an activation of brain regions, there's an increased activity of neurons, more energy is required, there's greater oxygen consumption. This results in more blood flow, and there's an increase in the regional blood flow as a result, and that hemodynamic response is localized to within 2 or 3 millimeters of the site of that increased neuronal activity. However, the total blood supply varies little between the periods of activity and rest. And the changes in blood flow that occur begin a couple of seconds to around 6 to 10 seconds after that neuronal activity. So how is that used in functional MRI? Is that a larger change in blood flow occurs rather than compared to that of oxygen metabolism. And what you have is an oxygen-rich and poor blood have different magnetic properties. And based on this principle, you have a gradient. And more oxygen if it's more oxygenated, then there's a stronger signal. And so what we look at is therefore the blood oxygen level dependent effect and in fMRIs, and it's a bold signal change that we look at. Now, nowadays, those of you who follow CNS imaging will realize that actually the preference is for functional MRI. And this is just because of several reasons. One is that there are better infrastructure, so there's more availability of MRI scanners than PET scanners. There's less technical staff that's required, though you do require a competent team for both. If you look at the technique, fMRI is far less invasive, doesn't involve radiation. And if you look at the images from an fMRI, there's greater spatial resolution, as well as temporal resolution as well. And what we look at is the change compared to a resting state, compared to an activity of neurons are happening. So one could perform this change either by pelvic floor muscle contraction and relaxation. So you have the relaxed state and a contracted state, or using paradigms like these, where you could have an infusion of the bladder and then drainage. So you have a change in activity, and this contrast is what's looked at. And this then gives you, following a statistical analysis, you get statistical maps that they'll tell you about the changes of activation. But essentially, the activation is coupled with the hemodynamic response. So what is the role of CNS imaging? So we look at sort of our understanding about lower urinary tract functions in health and disease. And this is probably the area where imaging has provided most of, been of most use. And so this is, so you look at bladder sensations experienced in ordinary life. And the current views of bladder sensations are derived essentially from urodynamic studies. And what you have is a continuing of gradually from one end of not, and then to increasing intensity and pleasantness. You have a first sensation, first desire, and then you have a strong desire to void. So there are a few centers in the world that have advanced the field of and applied fMRIs for understanding bladder functions. And Derek Griffith's work from the University of Pittsburgh has been actually quite in the forefront of this, particularly in understanding bladder sensations. And in this small cohort of healthy elderly women who were undergoing an fMRI study where they had a sort of an infusion sort of a drainage paradigm at low volume filling and mild sensations, consistently there were areas that were being activated in the anterior cingulate cortex, the insula, as you can see here, and also in the periaqueductal grave. In the same cohort with a more volume infused and now a strong desire, you find that there's more activation, particularly anterior cingulate cortex, as well as in the insula, and the activation seen in the insula is actually less diffuse and also shifts more anteriorly. And so these are areas that have consistently been shown to be activated, not only in these studies, but also from studies from other eminent centers where fMRIs and PET studies have been performed. Urgency, of course, is a pathological state where there's a complaint of a sudden compelling desire to pass urine, which is difficult to defer, and it's a defining characteristic of an overactive bladder. And it's often accompanied by diffuse activity in urodynamics. And in imaging studies, what's been demonstrated is that in individuals who demonstrate urgency, but not necessarily the true activity during the studies, there's a weakened response with smaller volumes that are seen. And this becomes exaggerated once the volume infused. If the paradigm is that there's a large volume infusion, you get this exaggerated response that's seen at that point. So this gives you an idea about the areas in the cortex that are involved in the perception of sensations in health and in disease. And based on the wealth of knowledge that's been acquired from different studies, there has now been a working model of lower unit control that is proposed in essentially 3 circuits of perception of fullness, urgency, and then a third circuit that involves the parahippocampus. And this therefore has provided immense insight into our understanding on the central neural control of blood functions. Now, what about understanding what happens following neurological disease? So there are several studies, small studies in Parkinson's disease, but I will focus on small vessel disease. Now, this is a condition that affects the elderly where doesn't present as a stroke, but often presents with a progressive syndrome of urinary incontinence, problems with mobility, and problems with memory. And studies have demonstrated a relationship between white matter changes and urgency incontinence. And in this study from the same group, and Stasatatic was first on this study, looking at sort of the relationship, it was found that in elderly, community-dwelling elderly individuals who were reporting predominantly urinary incontinence but who had significant white matter changes, there were specific areas of regional activation and DV activation that was more prominent and also correlated with the burden of white matter changes. And they found a correlation between these and specific white matter changes in the anterior thalamic radiation. So CNS imaging has therefore helped to understand the pathophysiological basis of blood dysfunction in specific neurological disorders. Now we move on into the clinical utility, which is the third part of this presentation. And this is where there is still work that's required, because we don't fully understand the relationship between what we see with what happens in health, and particularly in disease. And because these changes are representing changes in neuronal activation or activity, and we see patterns of activation and deactivation, but really we don't entirely know what this means. And also the studies are highly dependent on the details of the paradigm that's been used, the design of the study, and most importantly, the method of analysis and the statistics that have been used. So what is the role in clinical practice? And this is really what the future is about. Currently, to be honest with you, the translation into clinical practice is limited. But there are questions to be asked. Can patterns of neural activity in the brain identified during functional imaging paradigms be developed as a biomarker for urgency or for the overactive bladder? Are there different patterns of neural activation in patients presenting with the urinary urgency incontinence phenotype? And can the imaging changes be used to better understand the mechanisms of intervention for managing urinary incontinence? So from Derek Griffith's lab, Becky Clarkson demonstrated that there are actually different patterns of brain activation that are seen in people who respond to pelvic floor muscle training compared to those who don't. So could this be used as a predictor of response? Rose Carberry from Baylor has demonstrated changes in neural activity following detrusor injections of botulinum toxin. So all quite preliminary. And so I think this is an area that is really requiring research, but certainly provides potentially a biomarker for disease for future studies. Thank you very much.
Jalesh, can I ask a question, please?
Yeah.
So, Jalesh, this is very exciting, and we have been following this up for some time now. But if you think in the last, Derek's work was in 2007, so it's coming to about 15 years. So, do you think that it will evolve into one of the investigations we do as a clinical practice, or it will remain experimental? And if it is incorporated into clinical practice, will it replace urodynamics, or it will become complementary?
So I will answer the second part of that question first. I don't think this will ever replace urodynamics. It's like comparing apples and pears. Urodynamics tells you about bladder functions. This will tell you about the brain correlates. The utility, I think, partly is because these are all done in MRI machines, which are not away, or probably the other end of the hospital of the urology department. I think the future would be something that could be performed in the urodynamic suite itself, such as a near-infrared spectroscopy. The limitation of NIRS is that it doesn't provide you information about in-depth sort of changes in activation, but certainly will provide you cortical changes, particularly the frontal cortex, which is involved. So I think that is where probably the future will be. And I think what is essential would be to have a standardized paradigm that's used across different centers. I think also, particularly the work from Bertolt Bloch's group now looking at high resolution MRI with 7 Tesla will provide you more a nuanced approach in identifying a center in the brain, which could be used as sort of a center for the biomarker. But this is all work for the future, Rizwan.
Thank you.
Jalesh, what about spinal fMRI or spectroscopy?
Well, I intentionally left that out because I think that's even more exciting than brain. And so spinal fMRI is just coming up in a big way. And I think what will be exciting would be looking at changes in the sacral spinal cord. Currently, the spinal fMRI studies are all at the level of the cervical cord, but once it moves down to the sacral cord, particularly the gray matter, it'll give you information about what's happening in the gray matter of the spinal cord, which is where your parasympathetic nucleus that innervates to detrusor. And I think, particularly in patients with detrusor underactivity, this is going to be a very useful tool, of course, in the future. Spectroscopy, I'm not so sure. I think it'll tell you about metabolic changes happening in the neurons, but beyond that, I'm not entirely confident that it is going to be a game changer, at least in neurourology.
Tractography.
Yes, I've seen that question. So the question from Jane was, you talked about OAB urgency. To what extent could this apply to sensory painful urgency? And I agree that there is quite a bit of research actually into the painful and into bladder pain syndrome and understanding the neural correlates. I think it also opens up a question: what we're seeing. We see neuronal activation. It's just groups of neurons that have become active, and you see the hemodynamic response. So is it actually a correlate to a sensory signal, or is it the processing of that and additional areas? For example, the emotional component of pain or the emotional component of urgency. Is that what this correlates to? So I think there is a future for painful urgency and bladder pain. But I think how it relates to the patient's clinical symptoms is something that needs to be further understood if we're going to make sense of it and if it's going to become a clinical tool.
I have a question for the precedent presentation about what you told about the evoked potential after stimulation, electrical stimulation of the urethra and the mucosa. My opinion is that it is very difficult to record any potential from the detrusor, because you always stimulated both C and R delta fibers. So, and in neurogenic bladder, you know that mainly the afferent change to C fibers. So how maybe you enable to differentiate between evoked potential after stimulation of C fiber or evoked potential after stimulation of R delta fibers?
So this is, I would say it's probably a limit of my understanding, but the evoked potentials are essentially going to be following stimulation of the large fibers. And so, yeah. and I can only say that with a small fiber that's being stimulated, the latency is going to be longer. So I wonder, and this is, I have no personal experience with intravesical stimulation, but I wonder whether what you have is a more broadened peak, because you would have the faster conducting fibers and the stimulus arriving and being recorded from the scalp, and then later on you have from the C fibers and A delta. But it's
so
not
difference in latency probably.
Yeah, probably so. Yes.
So I don't see any question of the floor. So I propose we are on time, Roger, I suppose, Rob. Yeah, I will just make a summary of the study of the session. So today we have the occasion of discussing different diagnosis method, from the one presented by Rizwan Hamid on urodynamic and video urodynamic. We share his experience on the utility and the limitation of the technique. I try to explain you qualitative EMG, what is the role during avoiding cystomanometry, and especially in spinal cord injury, and what are the limitations. We also speak about vegetative testing, which are difficult to perform, except perhaps for the Dartos reflex, which is clinically easy to induce and reproduce. The other one are more reserved for research purposes. And Jalesh explain you us in detail all electrophysiological method you can use for diagnostic neurogenic bladder, pointing at the fact that bulbocavernosus reflex and EMG from the external and anal sphincter are the mostly used, evo potential remaining mainly for research purpose or for peripheral disease. And at least Jalesh present a nice talk on MRIs and imaging study with very fascinating results on fMRI. And we also discuss the utility of the technique and the future of new method of neuroimaging. So I want to thank you all for being present, and I want to thank Jalesh, I want to thank Rizwan, and I want to thank Rob and Roger for helping us to prepare this session. And I hope to see you live in a few time, and wish you and stay safe and healthy. Bye-bye.
Bye. Thank you very much.
Thank you.
Thank you.
Bye-bye.
Bye.